Welcome back, everyone. We have a couple more sessions before the conference ends. We're going to first transition into our closing keynote speaker. And I'm so honored to have my colleague, friend, mentor, and the most distinguished scholar of Hispanic health and aging that's influenced my own career and many of yours, people in the audience, Fernando Torres-Gil from UCLA. And he's going to make the introduction of our closing keynote speaker. Fernando?
Thank you. Good afternoon. At my ripe old age, when I get introduced, I begin to feel like I'm being given my eulogy. But I'm certainly been in the field a long time, and I know I've reached that point in life because I'm often referred to now as Don Fernando, which is a honorific reference to the elders of the community, but I take that with great pride. Let me thank both Jackie and Keith and Coco and the organizers of this tremendous event, conference, gathering, bonding opportunity, and really this opportunity to present the state-of-the-art knowledge, understanding, assessment, analysis of what it means to be aging as a Latino, to serve a Latino older population, and perhaps most importantly, to help prepare this nation for its inevitable demographic destiny, which all of you have alluded to in many different ways. If I can use a Catholic metaphor, you all remind me of the 12 apostles who were charged with one exception, were charged with spreading the gospel and creating a movement before the general public was aware that this new way of life would descend upon the world. And with the, I like the term, I think Coco used the tsunami, or Maria used the tsunami. In many ways, we are the apostles that know about certain trends that the public has not yet fully digested or understood, but will inevitably overwhelm them. And then they will turn and look to those of us who have been at this for many years to ask the question, please help us understand what this means and how we should be responding. So all of you should feel very good that you are at the forefront, beginning to develop that foundation of knowledge and understanding, which will be critical for the next 20, 30, 40, 50 years. And with that, it gives me great pleasure to introduce that individual that has been doing the same type of educational learning knowledge movement in Mexico. Dr. Luis Miguel Gutierrez Robledo, in many ways, is the pioneer of geriatrics in Mexico, the leading professional and advocate for aging issues in Mexico and throughout Latin America. You can read his bio in your program, and you can see that he's been an institution builder. He's now currently the director of our version of the National Institute on Aging, the Institute of Geriatrics, and the Mexican National Institute on Aging. He introduced the specialty of geriatrics at the UNAM. He was a member of the Advisory Council on Aging in Mexico City. I'm from Mexico City, and if you know the politics, that led towards a politics of aging, actually, in Mexico, and the founder of the Latin American Academy of Geriatric Medicine. We are truly fortunate to have you with us, Luis, because you represent, I think, that analogy I used here, but you represent that analogy in Mexico and Latin America. And those of us that study those trends know that if we think we're aging, Latin America is aging at a faster rate now than even the United States. And there will be perhaps numerically more older Mexicanos, older Latinos south of the border in due time than there are here. So we thank you for your leadership, for your building, and for creating the foundation for many more generations of gerontologists and geriatricians. I used the term when I talked to him earlier. Dr. Luis Miguel Gutierrez Robledo is Mexico's Robert Butler. We welcome you. Please come up. and share your insights. Thank you.
Thank you so much, Fernando. Thank you so much, Fernando. You're extremely kind, and I feel very honored by this invitation, and I want to acknowledge and recognize my gratitude to Jacqueline Angel and Cocos Marquez, who proposed also that I would be here today in order to share with you the experience of what we have been doing in the process of developing this institute, this brand new institute, the youngest institute and the smallest institute in the National Institutes of Health. We have 13 institutes of health in Mexico. This is the newest. We began working on the project in 2006, and the decree of creation was issued last year, and we began the administrative work for development ever since, and we began hiring the personnel by the end of February this year, and we are now in the process of identifying and contracting the research team, and I will be sharing with you some of the ideas, some of the people that are working with us. But I wanted to begin by saying why we choose this image that you see here down to represent the institute. Maybe some of you are familiar with the Nahui Olin, which represents the Cuatro Movimiento, the last son of the Aztecs, and in which the god of fire, Huehueteotl, dwells in the center of the universe, and this central part of the logo represents the movement of the life cycle. That's the idea behind the image that represents our institute. And well, I will be talking today. Excuse me, I missed the right order. I will be talking about the philosophy behind the development, why we are focusing on applied research, the opportunities for looking after differences between Mexicans living in Mexico and across the borders, some life course perspective on it, something about cultural myths, and some specific issues on frailty, the metabolic syndrome, dementia, and the possibilities of working together towards a common aim. So the mission statement of our institution is to promote the healthy aging of the Mexican population throughout knowledge production, enhancement, dissemination, and translation into common knowledge. We intend at the same time to gather and to generate new knowledge and to translate it to the decision makers in order to make the right political decisions in program development, but as well to begin working on translation into lay language for order to people to benefit of the knowledge that we already have towards towards achieving the goal of healthy and active aging. So we seek to contribute to the strengthening of the national health system. There were in 2005 8.2 million people over 60 years of age, and we expect this figure to double in a decade. And by 2040, one of every 4 Mexicans, 25% of us, will be aged more than 60 years. So this is one of the greatest challenges that we are facing today, and we are facing many at the same time, in fact. And we intend to be an answer to the pressing need for specialized courses and a permanent training program. We are responsible also of the geriatric specialty training at the National Institutes of Health, and we have 20 positions per year for residents in a program of geriatric medicine, people who have already had an internal medicine training and who come for 2 further years of training on geriatrics. And we have as well a program on geriatric nursing with the National School of Nursing from the National University, and we are planning to develop a program in social work as well. We collaborate with caregivers organizations such as the Alzheimer's Society, and the Institute is to become also and mainly a promoter for various lines of research about which I will be talking about a little bit further in the talk. And we will be collaborating in cooperation with the National University and a number of other institutions that I will let you see. And this is a brand new idea. In fact, this is the first institute which is transversal in its nature. So we have to coordinate the actions of research and teaching in several different institutes within the National Institutes of Health as aging concerns all these different perspectives of health. So as I said before, the issue, the decree announcing the creation of the Institute was issued on July 29, 2008. And in the decree, it is stated that the Institute is created in the first place to foster education and training on the subject of aging, then to develop and promote studies and research, then to assist the Ministry of Health in the design and implementation of a number of health programs, and to act as a national reference agency concerning issues related to aging. We have also to publish and disseminate studies and research reports on aging, and we have to foster the exchange between scientists on both the domestic and international arena by organizing meetings and establishing agreements with other institutions of the same kind. So our aim is to lead our population towards healthy aging. It's really quite a challenge, and in fact, we are not all together on the same line of thought when we are speaking about healthy aging. Different concepts have been discussed around this idea, but we believe that it is mainly, as the Swedish Institute for Public Health has stated, the process of optimizing opportunities for physical, social, and mental health to enable older people to take an active part in society. And from the policy perspective, we are aware that we have first of all to recognize that older people are of intrinsic value to society, and we have to work on the development of a new culture in which this will be self-evident. Also, we have to focus on health inequalities and recognize that most of the difficulties that people face when aging arise from these health inequalities and from differences in access to care. And recognize that the healthy aging policies rely strongly on prevention, and that we have to start very early in life. Towards successful aging, another alternative term, which refers to the maintenance of physical and mental function, and trying to remain active, as the World Health Organization has proposed. The European Commission, discussing the subject, has adopted a slightly different definition, but at the end it's more or less the same. In fact, we intend to move individuals to the highest level of function that is possible for their age. For this, we have to act in order to foster better lifestyles. We know a lot about the benefits of physical activity, of the maintenance of body composition through nutrition and physical activity, and the dangers of substance use or misuse. And maybe these three axes of action are particularly important. But successful policies in this area should have many potential benefits if we succeed in promoting this healthy aging. But in order to get there, we have to understand how people think about their own locus of control and the possibility of changing the course of their lives, and how can we stimulate changing lifestyle factors and how to stimulate the willingness of the elderly themselves in order to engage in the necessary activities, or not only the elderly, but young people in the process, how to direct them into the behavior that would benefit in the long run their aging process. So there are, we believe, two core principles, and Julio Frank was talking about this yesterday as well. The human rights perspective, in order, when you are in a society where priorities are in a very large number and much more heavily directed to the younger populations, it is difficult to discuss and to obtain the necessary resources to give the needed services to this population. But adopting the human rights perspective will certainly help a lot in this direction. In fact, the Seguro Popular initiative includes already a large space for the development of specific preventive health promotion actions and assistive actions directed to the maintenance and recovery of health of elderly people. And we are already working together with the Consejo Nacional de Población and the Instituto Nacional de los Adultos Mayores towards developing a common strategy to build a new aging culture that shows to this society the intrinsic value of elderly people. And that helped us transmit to the population the concept that it is never too early and never too late to promote health. We are also aware that we have to do a large work adapting health systems to the need of the elderly, and especially for the successful treatment of chronic disorders that demands a large amount of participation from the person itself as well as the primary caregiver. And we are working already in the development of a training program addressed to primary care physicians that will be formed to this purpose. I will be talking a little bit about health behavior differences between Mexican and North Americans and the impact on health and health-related behavior of cultural differences, but only very, very briefly because it has been widely addressed through this conference. And I will begin by showing you some graphs from this report that I'm certain most of you know very well, but that underline the disparities experienced by Hispanic elders, especially in the context of chronic disease, in the problem of not having access to preventive actions, and or not having the possibility of receiving the needed care for a specific disorders such as pneumonia, and how they are much less likely to receive, for example, cancer screening services. But they are also, as well, less likely to have an ongoing source of care and most likely to fall and less likely to receive counseling in order to ameliorate their lifestyle. You know that disparities in healthcare quality are staying in the States more or less the same or even increasing, and that for Hispanics and poor populations, in fact, the situation is very much alike. And I wonder if it is not rather because of this condition of being poor rather than Hispanic, which is determining what is happening to the population. And in access to health care, the disparities in access to care are staying the same or increasing as well. And for Hispanics, even in 80% of the core access measures, there was, in fact, an increase in the disparity. So a couple of years ago, 3 years ago, Jacqueline and Ron Angel published this reflections in the American Journal of Public Health. In fact, what is substantively important, and it has been underlined through the presentations in this meeting, is that the consideration of ethnic determinants is rather the identification of social and structural vulnerabilities at the end, and that is what really matters. And in this population, immigration status adds another dimension of complexity, particularly for those illegal migrants, which are in a very large number and who are underrepresented in the health statistic, in the population statistics. They are there. Nobody shows us they are there. Nobody counts them, but they are there. And they are there with their needs, and they are there with their health problems, and they have to deal with them in some way or another. They face blocked opportunities and poverty, disparities in health care access, and linguistic and cultural barriers. But there are maybe, as we have seen this morning, some protective factors as well arising from the community in well-organized communities, but this is not the case for most of them, for the migrants particularly, I mean. And the model, the theoretical model to help us understand the determinants of the intention to seek care and eventually the receipt of care is very complex. And it is partly determined by individual and partly by environmental factors. And there is a very, very important participation of empowerment factors that determine, once you have the intention to seek care, your possibility to do it. And health literacy in this population is very low, and health literacy is not only knowledge about disease, but knowledge about how to behave and how to manage to get the care that you need, which is not always straightforward. I believe that much work is to be done in disentangling the relationships between these different factors in order to have a better understanding of the determinants and the possibilities to intervene in order to reduce the disparities, the prevalent disparities. So much of the research has to be done on adding to the biomedical model of disease this ecological perspective that puts the illness in the context of a community and of enabling or disabling factors that allow the individual to use the health services as it would be needed. And we need as well a more comprehensive and useful conceptual model of healthful aging, to begin with a definition that includes not only the absence of disease and physical infirmity, but also this interaction with a very often adverse environment. This proposal for research actions have also have in fact been stated also by Jacqueline and Ron in the same paper that I was talking about before. And from my personal experience in research and the works that we have been conducting in this last few years, well, I have the intention now to address some issues on Hispanic health, mainly frailty, metabolic syndrome, and dementia, because we have data on the subject that it would be very interesting to contrast with your findings, and eventually to develop collaborations that would allow us to go further towards a better understanding of these very common disorders in our population, always indeed from the perspective of prevention and health promotion. Well, a lot has been said about this Hispanic paradox. This paper from Cocos Marquez in 2005 from the Journal of Gerontology states underlines the differences, and well, he has been lecturing on this this morning as well. I will not say much more about that, but after the discussion yesterday about the health status of native Mexicans in Mexico and how it seems very contrasting with this hypothesis of the healthier aging or the higher probability of survival in people of Mexican origin in the States. And after the findings that were shown yesterday by Eileen Crimmings, I went last night to look for the results of the ENSANUT, the Health and Nutrition Survey from Mexico, just to show you this a few slides with the same data that Eileen showed from another differences, just to let you see how, in fact, they agree. There are a little differences. Well, this is very clear, but this is extremely important. As you can see, in less than 20 years, the prevalence of overweight and obesity has tripled. And it has been a very fast phenomenon. It has increases. In fact, it has rocketed in this last decade. And it is afflicting mainly the youngest population and mainly the female population. And from the point of view of the prevalence of high blood pressure by age and sex, in fact, it reaches 60% of those older than 60 for men and for women and for men as well in those older than 70. But the only difference is that Eileen found that most of the cases were not detected or were unknown. In fact, the proportion is more or less even, half already known, half detected at the moment of the survey. And the data about prevalence of diabetes is very similar as well, and the prevalence has been rising as well in the last years. And there is also a very clear relationship between obesity and hypertension from the data coming from the Mexican Health and Nutrition Survey from 2006. And obesity is related also with a whole set of risk factors for chronic disorders: hypertriglyceridemia, hypertension, as already said, hyperinsulinemia, hyperglycemia, the metabolic syndrome, and an inflammatory status witnessed by high levels of C-reactive protein. And you can see that the number of risk factor rises as the mean BMI grows. So we are facing a generalized increase in obesity in all ages, mainly in young children, and we rank highest in the world, only behind the States, and I'm not certain that we're still behind by this moment. And the prevalence of disorders associated to obesity and the metabolic syndrome rise in alarming proportions. And as Dr. Ann was saying yesterday, maybe now it's the time for action. We already know enough about it. We know a lot about the risk factors, but we know very little about the possibility of changing behavior and of truly modifying this situation through specific interventions. And that is the point now. There is where we have to focus. This, and we have to act in several different levels. In the first level, there are not many things that we can change from the demographic point of view. People have a certain age, a certain gender, they are married or not, alone, but we cannot do a lot from that point of view. We can act to improve the living conditions, to ameliorate the socio-economic status, the level of education, income, and wealth, and the development of the different settings where people thrive. There's a lot to be done from that point of view, and in fact, most of the health achievements of the Mexican population come from interventions in that level, more than medical interventions. Then, in the second level, from the point of view of health behavior and lifestyles, we have an enormous lot of work to be done. And first, we need to have a better understanding of the determinants of health behavior and of the opportunities lying behind these concepts that would eventually allow us to intervene and modify this health-related behavior and the lifestyles. We understand more and more the role of biological risks, and we believe at least that we are able to modify this biological risk by pharmacological or non-pharmacological intervention. In fact, in several different levels, in blood pressure, in cholesterol, indeed we have been successful, and there is still a lot of room for success if we continue to increase our capacity for early detection and intervention and treatment. But we will have to do a lot of work in order to improve the health outcomes. Mortality has been improving, but morbidity has been increasing in the last few years. More people live more time, but with more illness charge throughout the years that they are, the extra years that they are living. And many of their health problems are related to the metabolic syndromes, that leads to a variety of disabilities that seemingly leads as well to frailty, and that could, by the occurrence of cerebrovascular disease, lead as well to depression. Eileen Crimmins published this paper by April this year, talking about the comparisons that you can make in the National Health and Nutrition Examination Survey in different populations according to their socioeconomic level and to their level of biologic risk. And she demonstrated how, in fact, the poor age more rapidly, and that the old populations that we are studying now are highly selected, and are populations of survivors and people with characteristics that would be as well very interesting to understand from the point of view of their survivorship and how they managed to get there in face of adversity. And it's especially in rural populations in Mexico, I think that we have a very interesting natural experiment that would allow us to identify some of the markers of the factors associated with successful aging, from taking this from a different perspective. And we know that there are genetic determinants that in a way participate in order to determine our longevity, but that the influence of the socioeconomic status and the allostatic load that you accumulated during your lifetime are much more important to determine the attrition of the health capital you are born with. And that this health capital can vary also depending on the developmental factors that come from pregnancy and the early weeks of growth, the very first weeks of growth, where the nutritional status of the mother and other environmental factors determine the setting of the metabolic thermostat, let's say, that will guide the development of the body throughout a lifetime, and determine how fast or how slowly you go into the decline of old age. Maybe the best definition of frailty ever published is the one by Kino. I agree with Maria that in fact we have no perfect definition of this entity, but an individual with sarcopenia, with accumulation of abdominal fat, with loss of teeth, with sensory deprivation, who is seemingly in good health and in face of minor adversity breaks down and collapses. Frailty, we have been interested in frailty, and well, I will not elaborate much on this, but I wanted to show this very different prevalences that come from different sources. We have been involved in two of these studies, the Tri-City study in France and the Mexican Health and Age Survey. From the Mexican Health and Age Survey itself, it is clear that we cannot use exactly the same criteria that Linda Fried proposed. We are using approximate measures, and certainly the high prevalence comes from that, for the lack of a specificity of the variables that we are using in order to identify the frail individuals. But in the case of the Hispanic PC, in fact, the criteria were the same, and nevertheless, the proportion of frail individuals in this population was by far much larger. And when you look at a set of European studies that was conducted in 10 different countries, I was surprised to see that with the same methodology of study, in Spain they identified also 21% of frail individuals. So there is something underlying there, and I am not certain because later on, a few days ago, I read this paper from San Antonio where they propose to measure frailty from a different perspective, taking account of cultural differences, and they, when they do so, there are no differences in prevalence, seemingly. So maybe there are biological differences, or maybe the criteria that, for example, exhaustion, or some of the criteria proposed by Fried have different cultural meanings and cannot be directly extrapolated into the Hispanic population. Anyway, there is room for research in order to have a better understanding of what is going on in this subject. The metabolic syndrome is for us extremely important. It is almost a matter of national security. As you have seen, it's extremely frequent, and there is a very clear socio-economic gradient in which poor people are at higher risk. And there are several outcomes that probably have been underestimated, in particular the mental health outcomes which are related to the metabolic syndrome as well. We are well aware of hypertension, we are well aware of diabetes, peripheral vascular disease, but not as much of the relationship that lies behind the metabolic syndrome and Alzheimer's disease, and I say, well, Alzheimer's disease and other dementias as well. Because it would be very straightforward to think about the relationship with vascular dementia. But in fact, when you take a look at some factors relating insulin, but this is the frailty syndrome, sorry, but I will come back to dementia in a minute. The metabolic syndrome has been related as well to the frailty syndrome, and Angela Abatecola has recently published a paper reviewing all the evidence relating the metabolic syndrome with the probability and insulin resistance to the presence of frailty. And one of the aspects that she considers that is not included in Linda Fried's definition of frailty is cognitive impairment. And here you have data from the National Health Statistics Report from the United States of America. The figures are very little, and I'm sure you cannot read them, but there are important sex differences, but for male individuals 60 years and older, the prevalence of the metabolic syndrome for Hispanics in the USA is 51%. For female of the same age, it is 54%. More than half of the Hispanic population have the metabolic syndrome. And when you see the frequency, the prevalence of this syndrome in the Mexican population, it is exactly the same. It's extremely high prevalence over 50 years of age. Half of the population has the disorder. But as you can see, when comparing the previous figures and this graph, indeed, the process begins much earlier in the Mexican population, and the figures rise earlier in life. Much has been speculated about the early life origins of the metabolic syndrome, and some researchers have tried to link the developmental process with an enhanced risk of several disorders, among them the metabolic syndrome, but as well cognitive impairment and more recently frailty. People who are exposed to poor socioeconomic status in infancy are also at risk of lesser educational achievements and to disadvantageous employment in adulthood. All this increases the risk of exposure to different factors that would increase their likelihood of enduring chronic disorders. And if to this you add that for infants, an impaired nutrition in infancy conducts to an impaired health status in infancy as well, to lesser growth, shorter height, and stunting, and that this is related with lesser passive cognitive reserve. If they have a poor education, they also have a lesser active cognitive reserve, and the poor health status in adulthood observed in the metabolic syndrome, which is also favored by genetic factors in our population, would lead to beginning from a lower level of performance to a faster multifactorial frailty and cognitive impairment. So if you see what would be the ideal life course trajectory, some people would be suffering of an early exposure with impact on reserve, and then a parallel life course, but in a lower level. Some others would be could eventually have a successful developmental process, but then suffer an adult age exposure that would accelerate the age-related decline. But in the case of our poorest population, people that are now reaching old age, they were early exposed, and they suffered an acceleration of this deterioration process in adult life, raising all this the likelihood of falling under the dementia or the frailty threshold and several other pathologies, complex chronic disorders that have multifactorial origins. Mark Hayward was asking yesterday, and I remembered, and in fact I found this slide that I had from a study that we conducted in 2005, measuring knee height, or looking at the relationship between knee height and cognitive performance in the Mexican Health and Aging Survey, the SABE survey in Mexico, and another, the Kronos survey, a survey on nutrition and health of the elderly. And what we found in that is that the relative risk of cognitive impairment decreased with a larger knee height in 2 of the surveys. In the 3rd survey, in Kronos, knee height didn't correlate, but arm length did. So I think that there is room for research on this perspective, looking at these markers of early development in order to test the hypothesis of less cognitive reserve, leading to an increased risk of cognitive impairment because of difficulties in early childhood development. From the point of view of genetics, some interesting findings have also been published. This comes from our research team, and we have a very large memory clinic that has been working for more than 10 years in the National Institute of Medical Sciences in an Alzheimer's disease in an Alzheimer's disease center in Mexico. And in the population served by this center, we didn't find a correlation between ApoE4 and an increased risk for Alzheimer's disease. Indeed, it has the ApoE4 phenotype has an influence on the evolution of the disorder, but it doesn't have the same weight, seemingly, as a determinant in the disease. On the other hand, this has not yet been published, but we have these results showing we have a total of about 300 patients, 90 cases and 180 controls, 90 cases of Alzheimer's disease and 180 matched paired controls. And when we looked at the differences in the prevalence of the metabolic syndrome, we found that it was 6.7 times more frequent in patients with Alzheimer's disease than in controls. And evidence in the same direction has been published by researchers in Spain and in Sweden. So it seems that the metabolic syndrome goes beyond increasing the risk of vascular dementia and probably having some role as well in the evolution of Alzheimer's disease. Ever since the paper by Fried was published proposing the criteria to identify frail individuals, I was intrigued by the fact that she didn't include cognition as one of the elements. And ever since we have been working, trying to understand the relationship between cognition and frailty, and very recently this year we published this paper together with our colleagues from Bordeaux and with José Alberto Ávila Funes, which is actually the head of the Geriatrics department in the National Institute of Medical Sciences, in which it is shown that adding the element of cognition into the model increases the predictive validity of the frailty phenotype for adverse outcomes, and that some frail individuals have also an increased risk of developing dementia. But those that develop dementia had at the outset, at the baseline examination, already some degree of cognitive impairment. Those who were intact at the outset didn't develop dementia at follow-up, and it doesn't matter if they were frail or no. It seems that there are two processes running in parallel, leading either to frailty or cognitive impairment, and sometimes they can overlap, and some factors, some risk factors could be shared, such as the metabolic syndrome. Well, so there are many questions to be addressed that rise from what I have been saying. We are very much interested on the early development as a determinant of disease in old age, and about the role of the metabolic syndrome in relation to dementia and frailty, to socioeconomic gradients, and to the understanding of cultural and environmental effects, and eventually of genetic differences. And I believe that we are in a privileged position because, well, if we succeed in establishing partnerships with researchers in the United States on the same field, we would have the full picture. The indigenous population, the population of indigenous origin in Mexico, the mestizo population, European population in Mexico, migrant population, the population of the United States, and eventually, well, we have access also to other survey studies in Spain and in France. In Spain, the Toledo study and the Tri-City studies in France, which is very large and has been running for already 10 years. So very interesting comparisons could be established in order to have a better understanding of some of these questions. Many things are already being done in the National Institutes of Health in Mexico in the field of aging. I will briefly describe what we are bringing into the research arena and some opportunities for networking, but very briefly, as I see that the time is running out rapidly, and some words also about the Latin American Academy for the Medicine of Aging. Well, these are some of the National Institutes of Health. We work with the National, it all began in the National Institute of Medical Sciences, where 20 years ago we created the Department of Geriatrics, 10 years ago the Memory Clinic that are still working. Then geriatrics departments were created as well in the Instituto Nacional de Cardiología, in rehabilitation, in neurology, and in the National Institute of Psychiatry, and we are working together with the Instituto Nacional de Cancerología in the development of an oncogeriatric unit that will be launched on November this year. And much of the research on public health and aging has been conducted together with the National Institute of Medical Sciences and the Instituto Nacional de Salud Pública. We are then creating a new institute in the Federal District in Mexico City, an institute which we intend to relate to a much larger Mexican gerontological network. We are already working with people at the Facultad Latinoamericana de Ciencias Sociales, Virgilio Partida Bush, at the Instituto Mexicano del Seguro Social, Carmen García Peña, and in the already mentioned National Institutes of Health. And we are now soon to be located in downtown Tlalpan, in this old 18th century house that we will be occupying probably by the end of this year, and where in the parking lot that you see above, we will build the laboratories and the teaching area, trying to preserve the garden. This is a 17,000 square meter terrain. It's large enough to house the institute. And we are going to, in fact, we have begun our collaboration with these institutes of health, with the high specialty hospitals, which are also 13 that are being built all around the country, and we have the mandate to create a geriatrics department in each one of them, and to prepare the geriatricians that will take care of those centers. We have been collaborating with the research unit on aging in the Mexican Institute of Social Security, and not only with medical care institutions, but also with the Universidad Nacional Autónoma de Mexico, with the Faculty of Medicine, where our specialty program is based, It was created in 1994. We have trained ever since about 150 geriatricians in the whole program and in the Institutes of Health 50. We are related as well with the Biomedical Research Institute, with whom we will be collaborating very closely because we have hired biomedical researchers that in the first 2 or 3 years will be working in this Biomedical Research Institute. And we have been related as well with the CISESE, where they in the Computer Sciences Center have developed since 3 years ago a gerotechnology program. And we are working together with them in order to develop research in that direction as well. And we have been collaborating for many years with Roberto Ham and Silvia Mejia in the Center for Demography of Aging at the Colegio de la Frontera Norte. And we have several, we are related as well with the Mexican Health Foundation, and we are looking forward to foster the development of international partnerships. Since 20 years, we have been collaborating with Toulouse, la Université Paul Sabatier à Toulouse, and with l'Université Victor Ségalen de Bordeaux, where I obtained my PhD, and the Institute for Public Health and Development in this university, and where the Tricity studies is based. And now we are beginning to work with the Gérontopole Alpes Méditerranée, which was originally based in Grenoble, but is now migrating to Nice. And we have people. Alberto Avila was trained in the Institut de Geriatrie de l'Université de Sherbrooke, and he keeps a very close relationship with them. In fact, Hélène Paget, who is directing this institute, during her sabbatical year, stayed 6 months with us, helping us in the development of the project of the Geriatrics Institute. And we keep the relationship with her as well as with Howard Bergman at McGill University. And certainly with our friends of the Silly Center on Aging, and particularly with the PAHO Collaborating Center, where hopefully the follow-up to NSM will be based. And we have been working at the same time in these last few years in the development of a network of collaborators at in the Latin American area, what we call the Latin American Academy for the Medicine of the Older Adult. Which has the following mission statement: we look forward to improve quality of care and access to health services for older adults in Latin America throughout a very elitist activity, which is teaching and homologating the competences of teachers of geriatric medicine in the region. And this is the executive committee. We are all there. And we have been working with Carlos Alberto Cano from Bogotá, myself, Pedro Paulo Marín from Chile, Fernando Morales, Costa Rica, Jose Francisco Parodi in Lima, with Marta Peláez for many years, Leocadio Rodríguez Mañas from Spain, Enrique Vega now in Pajo, and Clemente Zúñiga in Baja California, Tijuana. And we have executive committee members all around the continent. And we have been working in knowledge enhancement, mainly through training sessions that are carried on every year since 8 years ago in different countries of the region, looking towards the development of common criteria for geriatricians in the region. Last October, we began working on guideline development on the homologation of teaching programs, and we worked already in the second edition of a primary care manual. We also continue to work in developing continuous learning and research. We are to meet next November in order to see what can we do together with the cohort studies that have been developed in the region and in Spain. And we try to develop scientific interest in geriatrics teachers, so the members of the network have learned about evidence-based geriatrics, systematic analysis of evidence, and now we are beginning with this first initiative for multicentric research. We are planning to develop. This morning we were discussing about the creation of a distant learning space in the PAHO website together with our institute in a strategic alliance to open a virtual library and a distant learning program, and in a specific website that we will begin working on very, very soon. And we try to assess what we do, and we have been measuring the impact of the development of this training program throughout the region. You can see the places where ALMA graduates are. There are more than 50 now, and this has been a very, very successful initiative. So the Instituto de Geriatría, and I think I will stop here, because I could talk hours and hours, but I have gone through the time. Well, there's a general direction, a research division, a teaching division, and the administration. We will be working on biomedical and clinical research, on epidemiological research, in biomedical, biological, and gerotechnology, in epidemiological, clinical, geriatric epidemiology, and the public health perspective. We have the academic formal training and the continued learning direction, and we are already working in medical and nursing training and soon in social work. We have a methodological support unit for research. We work certainly in distant learning, and we are working towards the development of this website for scientific communication. And we have also an infrastructure for administration. And we are 29 academic positions, 16 support positions, not much people. Myself in the general direction, Flor Avila teaching direction, Elizabeth Caro in the continued learning and dissemination vice direction, Maria Isabel Negrete in formal training. She's a nurse. Then Varinia Herrera, and we have already recruited some researchers for developing of the 4 research axes. I will go through this very fast. First of all, Jesus Gutierrez Avila, who is a Master of Public Health and had a postdoc fellowship in epidemiology at Hopkins. Mariana Lopez Ortega, who's coming back from London in a couple of weeks. Cesar Alfredo Gonzalez, who has been working at Galveston. Marta Liliana Giraldo, who is very well known to Veronica Montes de Oca. Diana Torres, a social worker with Master in Public Health. And in Biology of Human Aging, we are incorporating Victoria Ramos, a nutritional specialist. Shaddai Michan, coming back from a postdoc, a large postdoc of 5 years in Harvard. Armando Luna Lopez, Luis Bernardo Tobar, and Oscar Rosas, Dolores Mino, pharmacoepidemiologist, Douglas Nance, nursing and mental health, Maria de Lourdes Avila, gerontechnology. And we have, as the one responsible for networking, the actual president of the Public Health Board of Specialists, and a social anthropologist who is working with him and who is responsible as well for the administration of the databases that we have available nowadays. Well, you know very well, NSM, and it is not ours, it is available to everybody, and we have used it extensively. We have access to another survey from the ISTE, the Social Security of the government, to the program and that has assessed the performance of the Oportunidades intervention in the poorest population in the country. The recently developed Coyoacán cohort that has barely been exploited, and there's a lot of data on the metabolic syndrome and frailty on this. Then the study from the Mexican Institute of Social Security, the dementia cohort, the study of Ana Luisa Sosa, that we will be incorporating to the Coyoacán cohort, homologating the assessment from the 1066 initiative and our variables from metabolic syndrome and frailty, and several other data sets that will be the initial inputs for our researchers who are meeting today in order to get acknowledged with these databases and to begin developing the strategic planning for research. So we have a workforce integrated. I didn't show you all of them. By 14 researchers, we still have 4 research positions available, the highest level research positions that have not yet been filled. And we have available data sets for comparisons, new ongoing surveys such as the Coyoacán survey, the possibility of exchange and collaboration, and the possibility of postdoctoral training financed via the Carso Institute, among other possible sources of funding. And I believe that would be all. Thank you so much for your attention.
Thank you. We have time for 1 or 2 questions before we transition to our consensus building. Yes.
Back in the middle of the talk, you were talking about social structure still matters, and under that was vulnerabilities like social or linguistic factors and opportunities that were blocked. And there was one phrase there, something about protective factor. Can you expand on that a little bit for me?
Yes, this kind of protective factors refer to such environments as the one that was described this morning. How a community with a large structure, a well-structured Hispanic community, diminishes the risk of becoming frail.
Thank you.
For example. Yes?
Dr. Gutierrez, excellent talk, very stimulating. Dr. Martinez with the Hawk Foundation for Mental Health. So, as you can tell, my question is going to be about mental health. In October 2006, the National Association of State Mental Health Program Directors came out with a morbidity mortality study in reference to people with serious mental illness. And they determined the main thing from that study was that those with serious mental illness during their lifespan, actually their lifespan is cut 25 years short. And I'm wondering if you have, in your studies and in your institute, determined, is this the same phenomenon occurring in Mexico as well?
We have not enough follow-up information on this subject. The only large-scale mental health survey that was conducted by the National Institute of Psychiatry excluded old age individuals. So we do not have much information on this. And our public health information system is not very performing from the point of view of mental health. So it would be difficult to extrapolate data from this. We do not know that.
Okay. Could I have a follow-up question?
Yes.
This is in reference to the metabolic syndrome, which obviously, as you pointed out, is very closely tied in with the delivery of care to those with serious mental illness. Have you seen any regional changes in reference to the metabolic syndrome, say like in La Frontera? Or the closer you get to the interaction of the two cultures coming together?
We have to conduct an analysis of the NSM data from that point of view. We have not yet seen. I don't know if Rebecca has been able to look at this. We suspect that it is happening, but we have not yet done it.
Okay. Thank you very much.
Well, thank you so much.
We have a presentation on behalf of the advisory group and our co-organizers, Cocos and Keith and Fernando. We wanted to thank you for your participation in the conference series on Aging the Americas. This is third installment. We hope you come back.
Thank you so
much.
much.
And this is a small token of our appreciation. And I do want to mention that Hector Gonzalez was very helpful in commissioning this lovely artwork. Hopefully all of you can see it. And it has very symbolic meaning. And if I indulge me for 1 minute here, because I would like to read it to get it right. This image is a la mariposa monarca, or a monarch butterfly. And it's selected this monarcha, this monarch butterfly, to symbolize the threads that unite us across the Americas in understanding and reverently preserving the dignity and integrity of life cycle that knows no other, beginning or ends. So thank you again, and I hope you enjoyed this.
Thank you so much.